This is a study that looked at surgery trials. This was for CVA, so cardiovascular, so stroke or death after carotid endarterectomy with patching versus primary closure. If you look at the early trials, they're here. They all show beneficial effects on stroke or death, but then you look at the bigger later trials, no benefit at all. And so the results were very different. So consistency across higher quality RCTs is critical. This is something that many guideline groups completely ignore. They see one or two trials and they say, that's good, let's go. But reproducibility of results, that's really a core principle of the scientific method. If you can't reproduce results across settings, that's a problem. If you can't do this in controlled settings, academic centers, how do you expect people in clinical practice to reproduce their results at what they're doing? So reviews that ignore or downplay inconsistency or sparse data really don't meet current standards. This is a quote from West et al. They did a review for AHRQ back in 2002, and they say, consistency has only recently become an integral part of the systems reviewed in this area. The authors see this as a useful advance, and everybody's incorporated consistency now. Here's another example, magnesium for myocardial infarction. They had 7 trials with 1,300 patients that showed benefit. That's many more patients than we have for any interventional therapy, 10 times more. But a subsequent large trial showed no benefit. And again, the quote, several medium-sized trials of high quality seem necessary to render results trustworthy. Here's another real-life example. Glucose control in surgical ICU patients. There was a trial in 2001 that showed tight glucose control resulted in decreased mortality, and this was enthusiastically taken up by many guideline groups. However, we have 5 subsequent trials that have shown no benefit on mortality. One actually showed increased mortality and were causing a lot of hypoglycemia. And so actually the guidelines are now changing, and people jumped on this too quickly is basically the issue. There are some misconceptions about quality rating that I wanted to bring up. The first is that there's no such thing as an ARC method for rating the quality of studies. People say, well, you say you based your stuff on ARC methods, but it's different than what's in this study or whatever. Actually, that report by West et al. Is, number one, outdated. It was published in 2002. And number two, it didn't report an ARC method. It reviewed multiple systems for rating quality and identified important domains that they thought quality rating systems should incorporate it, and it concluded that many different systems could be used. The quote is, many systems covered most of the domains that are considered generally important. From this set, the authors identified 19 generic systems that fully address our quality domains, and they basically say any of those could be used as a starting point. These were our criteria for rating a body of evidence. To be high, we wanted 2 consistent, higher quality RCTs. This is not a hard standard to meet, or shouldn't be a hard standard to meet. If you came to the FDA and said, we've got 2 RCTs, will you approve this drug, they would laugh at you. So we don't think these are very high standards. Even for moderate quality evidence, it's even less. We just want 1 higher quality RCT or 2 trials that don't have a lot of inconsistency. This is a grid that's from the U.S. Preventive Services Task Force. I think the only important thing to note here is that you look at both the quality of the evidence as well as the net benefit to come up with an overall grade. And this was the recommendation grid. You use both the quality of the evidence and then a judgment over whether you think something works or not. And if you can't tell whether something works or not, you have to give it an I recommendation. There are some challenges in developing guidelines for interventional procedures. One is that FDA regulation of medical devices is limited, as well as the procedures associated with them. Drugs require many RCTs with thousands of patients, whereas devices are often approved without RCTs. The procedures themselves are not regulated. Generally, there's small numbers of trials. The exception is epidural steroids. There's some questions about the utility of the invasive diagnostic tests that we'll go into. And we have problems with sparse data and inconsistent results. I don't see how anyone can look at the evidence and deny that there's issues with sparse data and inconsistency. For non-radicular low back pain, here are some of the issues. We actually have no data from RCTs, SI joint injection. This is based on our 2008 review. RCTs that show no benefit or clear benefit for facet joint steroid injections. We have inconsistent results in sparse data, IDED and radiofrequency, or we have poor quality evidence. We've seen promising results from non-randomized studies that haven't been replicated in randomized trials. We don't know whether it's because the interventions are ineffective or if we're not selecting patients well. I want to go over this example. This is radiofrequency denervation. So of the interventions that we say we have insufficient evidence, this is probably the one where we actually have the most RCTs by far. These are the 7 trials. These are sham-controlled trials. There's 3 trials that you kind of throw out, right? I think most people would agree. The Gallagher study, there's methodological issues. The Tekin study, there's also methodological issues. And the Van Wyck study, there's technical issues. We think that they went kind of perpendicular to the nerve instead of parallel to the nerve. So most people would say, okay, let's throw out those 3 studies. They're not really informative. This is what you're left with. 3 studies with a total of 140 patients. Again, tiny numbers, tiny sample sizes compared to most other interventions. 2 of them used uncontrolled blocks, which you guys don't like. They gave different results. One showed no benefit. One showed a 1 to 2 point benefit. The only study to use a controlled block had big baseline differences, 1.6 point baseline differences, which are exactly equal to the beneficial effects. Actually, if you look at the end pain scores, they're exactly the same in the 2 groups. So looking at this, objectively, how can you say whether radiofrequency denervation is effective or not based on the randomized controlled trials? This is where we're coming from. This is the kind of evidence we're looking at. For IDED, it's basically 2 studies with inconsistent results. Is it appropriate to use interventions not supported by evidence? Well, we think that therapy supported by stronger evidence should be prioritized. Not recommending therapy supported by weak evidence is very consistent with evidence-based principles. And clinicians should consider those therapies only when you've tried alternatives and they've failed, patients are still suffering, and patients are really clearly informed about the uncertainties about what's going on. I think there's actually medical legal issues there. Other factors to consider are the potential harms, benefits, and costs. This just contrasts the APS recommendations from the NICE recommendations. We actually took a more conservative approach. The NICE people said if we don't have sufficient evidence, we're going to say don't do it. We just say insufficient evidence for IDED and PERF, radiofrequency denervation, sacroiliac joint steroid injection, intradiscal steroid injection. This means that we think that people should be doing the studies to look at this stuff. The decision about whether you're going to do it or not, we didn't make that call. So I know I'm a little bit over time, but we started a little bit late too. I want to get into the diagnostic testing. So consider a hypothetical test for diagnosing fibromyalgia. So what would your reaction be if you were told that we don't have a reliable reference standard, so we don't know the sensitivity or specificity. Some people who don't have generalized pain at all have positive results on the test. We don't know whether using the test improves clinical outcomes compared to diagnosing fibromyalgia based on clinical grounds. The test is invasive and painful, and it could cause long-term injury to muscles. Would you recommend this test? Just think about that. There's a diagnostic test hierarchy of evidence that differs a little bit from when we're looking at efficacy trials. Studies that directly assess the effects of testing on patient outcomes are at the top of the hierarchy. These actually look at clinical efficacy. They incorporate the effects of test results on subsequent diagnostic and therapeutic decisions to look at what we really care about, which is what is the impact on patient outcomes. Studies that assess intermediate outcomes provide indirect evidence about effects on patient outcomes. This can be therapeutic impact, whether you do additional testing or procedures, diagnostic accuracy, whether you can accurately tell whether somebody has a condition or not, whether you can distinguish symptomatic from asymptomatic patients. This is a low level of evidence because it's not relevant or useful for clinical practice. We're not trying to figure out if somebody has facet joint pain when they don't have low back pain. We want to know what happens. We have to sort out what's happening in people that actually have symptoms. And then at the bottom are kind of the technical studies, just how do you get a good test. This is the algorithm from a recent paper from BMJ that talks about evaluating diagnostic tests and how the randomized trial provides information about outcomes important to patients. That's what we care about. This is an example for low back pain. So again, at the top, do patients who undergo the test, we can say for provocative discography, fare better than similar untreated patients. Those would be studies that look at clinical efficacy. And the example would be, do patients with low back pain who undergo provocative discography experience better outcomes compared to those who don't? The next is a therapeutic impact, which is basically, if you undergo, whether you undergo discography whether you receive different treatments. Again, that's an intermediate outcome because we don't know what the effects of those treatments are necessarily. Diagnostic accuracy, how well does discography actually identify discogenic back pain? A lower level of diagnostic accuracy, whether you can distinguish people, whether you get positive tests in people with low back pain versus persons without, and then how do you actually do a provocative discography? What we have is that we have no reference standard for any of these procedures because there is no gold standard. Imaging is not a good reference standard. If imaging was the gold standard, we wouldn't need to have other invasive procedures. For discography, we know that false positives can occur in people that don't have low back pain, but have pain in other sites, prior surgery, somatization, etc. And again, distinguishing people with symptoms from those without is a very basic preliminary standard for a diagnostic test. If you had a test for heart attacks that was positive in people that didn't have chest pain at all, that would be very worrisome. This is really an example of extreme spectrum bias, what we call, and they're really the diagnostic equivalent of case series, the ones that look at whether you get positive results in asymptomatic persons. Pressure criteria does reduce the number of positives in asymptomatic people, but doesn't completely eliminate them. We have no high quality evidence that clinical outcomes are improved in people who undergo discography compared to those who don't. There's some potential long-term harms related to disc degeneration. We're not sure how controlled and other methods improve the test performance. So this is a summary of the evidence for provocative discography. We have a few and flawed studies that compared outcomes in persons who did and did not undergo discography. There's no clear effect on clinical outcomes. We can't estimate the sensitivity or specificity because there's no reliable reference standard. We do see some positives in patients without low back pain. They seem to be reduced with use of positive pressure criteria. But again, this is the equivalent of case series for diagnostic testing. And then there are technical issues. You guys are evolving and learning how to use positive pressure criteria, controlled injections, etc. Controlled settings, academic centers, how do you expect people in clinical practice to reproduce their results at what they're doing? So reviews that ignore or downplay inconsistency or sparse data really don't meet current standards. This is a quote from West et al. They did a review for AHR. This is a study that looked at surgery trials. This was for CVA, so cardiovascular, so stroke or death after carotid endarterectomy with patching versus primary closure, back in 2002. And they say consistency has only recently become an integral part of the systems reviewed in this area. The authors see this as a useful advance, and everybody's incorporated consistency now. Here's another example, magnesium for myocardial infarction. They had 7 trials with 1,300 patients that showed benefit. If you look at the early trials, they're here. They all show beneficial effects on stroke or death, but then you look at the bigger, later trials, no benefit at all. And so the results were very different. So consistency across higher quality RCTs is critical. This is something that many guideline groups completely ignore. They see 1 or 2 trials and they say, that's good, let's go. But reproducibility of results, that's really a core principle of the scientific method. If you can't reproduce results across settings, that's a problem. If you can't do this in